Thanks so much, Tina. Good morning, everyone. As Tina mentioned, I'm Steph Pauluso. I'm the Central South Regional Stroke Program Director. I look forward to spending the next few minutes with you talking about the Regional Stroke Network and really how data is such an important part of what we do to try and improve stroke care across our region. I'll start today with a little bit of background on the provincial and regional organization of stroke care in Ontario. The objectives for the next few minutes are as follows: is to describe that regional structure and provincial structure and how that relates to best practice implementation, discuss the Central South Regional Stroke Network and our mandate, and then quickly spend just a minute or two on some of the integration models within our region. And the reason why we'll spend some time looking at those is to understand why we often see persons with stroke moving across our region from site to site. And then at the end of this section, there will be a couple of minutes for any questions or discussion. So in about the year 2000, just before, the Ontario stroke system was developed. So the Ontario stroke system is a system of regional stroke networks that were developed to improve stroke care delivery across Ontario. The province, as you can see with this diagram, was divided into 11 regional stroke networks. And within each of those regional stroke networks, there is a regional stroke center, and many have district stroke centers as well. Each region is tasked with implementing stroke best practices across their entire geography and has a small team that is dedicated to this work. Additionally, each of the regional teams has a connection with the rest of the province and connects with colleagues from each of the regional stroke networks across Ontario, so that not only is stroke care being driven region by region, but successes and opportunities are shared across the province to really work together to improve stroke care for all. This is an overview map of the Central South region. So from a geographical perspective, as you can see, it covers quite a wide geography. It covers from Niagara to Brant Haldeman, Norfolk, up into Kitchener-Waterloo and Wellington County in Guelph, and then down between Hamilton and Burlington as well. So it's a very large geography. It also has a mix of urban and rural populations. So it allows us to utilize different strategies for best practice implementation across Central South Ontario. And this is the service map of the region. And what I mean by that is, in terms of hospital care, the different sites and services available through the region. So, as mentioned, in terms of our geography, it's large, and it consists of what would have been previously known as the Waterloo Wellington LHIN and the H&HB LHIN. We don't have that language anymore, but that's the part of the Ontario West region that the Central South Regional Stroke Network is in, the old Waterloo Wellington LHIN and H&HB LHIN. And we have many teams across the region that work every day to deliver best practice stroke care and ensure that quality improvement is part of what we do every day. On this map, highlighted in black and red, you can see our regional and district stroke centers. And I know it's a little bit small there, but the black circle in the middle is representative of the Hamilton General Hospital, which is the regional stroke center for Central South Ontario. And then the red circles are the district stroke centers in our region. And so those are Niagara Health Niagara Falls site, Brantford General Hospital, and Grand River Hospital as well. In our region, and we won't go through the entire map, but just to note, to give you some sense of the stroke services that are available through our region. In our region, we also have additional thrombolysis delivery sites, so clot busting medication at Guelph General and Joseph Brant Hospital. There are 6 dedicated acute stroke units, or at least part of an integrated stroke unit, along with 6 stroke rehabilitation units across our region. And then you see a number of other bullets there, and those are all the other hospitals within our region. And so as the Central South Regional Stroke Network, we work with all 22 hospitals and numerous organizations and agencies, inclusive of our paramedic partners, March of Dimes Canada, Heart Stroke Foundation, etc., all in an effort to collaborate and improve stroke care across the Central South region. This is the small and mighty team that I referred to just a couple of slides ago. Each region is responsible to maintain a regional and district stroke team. And so this is our team. And as you can see, a couple of our presenters are here today, me and Rhonda, part of the regional and district team. But we have different folks who are specialized in different areas. So we have team members who focus on acute best practice implementation, rehabilitation and community reintegration, data and education. We have team members who are leads in specific geographies for our districts in Niagara and Brent Haldimand, Norfolk, and in Waterloo, Wellington. And we have multiple physician leads who really drive the medical best practice implementation across the continuum of care. So I'm often asked, if you had to sort of boil this down, what is the mandate? What does the Regional Stroke Network do in just one sentence? And so if I was to break it down into one sentence, it would be each regional stroke network is meant to facilitate the implementation of stroke best practices across the entire continuum of care within each region. And for us, it's within the Central South region. This is inclusive of public awareness, pre-hospital care, stroke prevention, hyperacute care, acute and stroke rehabilitation, and community reintegration as well. As mentioned at the start of this presentation, facilitating the implementation of stroke best practices is really the mandate of the Central South region. Our three strategic pillars that have been approved by our Regional Stroke Steering Committee are to advance the implementation of stroke best practices across the continuum, to foster collaboration and networking in the implementation of best practices in the region. I always like to say that in our region, we don't want anyone to feel like they're doing something alone when it comes to stroke best practice implementation. We are a team and we are meant to work together to drive this forward. And also to provide evidence-based education as our third pillar for healthcare providers working in stroke care and also to develop their stroke expertise. And also part of our educate pillar is to increase public awareness and knowledge about stroke. We hope that these pillars of our strategic plan really help improve performance and outcomes in stroke care across our region. Okay, and as a last slide here for the introduction, I'll just quickly talk a little bit about the integration models. And so as mentioned in the objectives, I just wanted to take a minute to discuss these models in our region because I think it's important to note that they can account for some of the reason why you may see in the documentation patients with stroke in our region moving across from site to site. In our region, we have 6 sites that I mentioned earlier that deliver the clot busting medication or thrombolysis. And we have 1 site in our region that is able to complete endovascular therapy or clot retrieval therapy. And so endovascular therapy is a procedure where the clot that is causing the stroke is actually mechanically removed in order to restore blood flow to the brain. So often patients who are evaluated through the region for eligibility for endovascular therapy are quickly transported to the Hamilton General Hospital for this procedure. Additionally, we have numerous integration models where if a patient has a confirmed stroke, we try to get them to an acute stroke unit as quickly as possible. And so as quickly as possible, they are transported to the acute stroke units at one of the 6 hospitals in our regions that have the dedicated acute stroke units. As well, you can also see motion with patients moving from acute care to rehabilitation. And so sometimes this is within the same center, but sometimes it requires a patient moving to a standalone rehab center. A good example of this in our region is the movement of patients from Niagara Health Niagara Falls site to Hotel Dieu Shaver, from acute care to rehabilitation. And then just another thing to note here, because there is this motion of patients within our region to get them to a specialized stroke center, oftentimes there are patients requiring repatriation to their home hospital. And so that is another area of integration where we see patients moving through our region. So again, that was very high level, but I hope this helps clarify again why you might see some patients moving from site to site and then back to their home sites quickly through our region in order to access specialized stroke care. So that was a whirlwind overview of our entire region and some of our best practice implementation approaches. Maybe I can take a minute here. Tina, I'll just note, I can't see the screen right now. So if there are any questions, could you let me know? And I'm happy to answer them before moving to the next section.
Yeah, absolutely. If anyone has any questions, they can put it in the chat or in the Q&A, or if you feel like raising your hand, can allow you to unmute.
And if there's no questions, that's okay too. I've got another few slides to go through and can take questions at the end of that as well.
Okay, no questions are coming up, Steph, so go ahead and continue.
Okay, perfect. So in the next part of the presentation, I'd like to spend a bit of time talking about how important data and data quality is and how it informs funding. So first we'll look at funding reform that has occurred in our province and a little bit about QBPs and how accurate coding is so important to these. And I do want to give credit to Ellie Wisniewski, who Ellie created these slides, and I'm just going to be speaking to them. So healthcare funding has moved from global funding, which is a historical approach where health service providers received a lump sum of funding, through health system funding reform, which is an evidence-based approach with incentives to deliver quality of care based on number of patients, services delivered, best practices, and the needs of the population. As the health system went through funding reform, the budgets were broken down into 30% global funding and 70% patient-focused funding. The patient-focused funding is based on patient population and reflects the disease, diagnosis, treatment, and the acuity of the clinical cluster. Patient-focused funding is broken down into HBAM and QBPs, broken down 40% HBAM, 30% QBPs. HBAM is a methodology that determines funding based on patient demographics, clinical, and financial data. And QBPs are evidence-based targets, quality of care clusters that will be allocated funding using an equation of price times volume. So it's really clear as we quickly review those funding methods that the importance of accurate coding in order to evaluate those funding models and utilize those funding models. And really, coders tell the patient's story by converting clinical documentation into standardized codes. And it's from this coding that resource intensity weights and hospital inpatient group weights are determined and calculated, and that really informs our HBAM funding model. And so obviously very, very important. And when it comes to QBP funding, coding remains incredibly important as certain clinical handbook stroke categories are included in the QBP funding approach. And once those categorizations are completed, the equation, as mentioned earlier, of fixed price times volume of cases is then used to determine the QBP funding amount. So that was a bit about how the accuracy and quality of coded data helps inform funding. Now I want to just spend a couple minutes on really how data is used in our region for the basis of quality improvement and for really any stroke organization across the Central South region. As a goal for our region, we always look to continually improve stroke care. And so it's extremely important to our work and of all of this leads to improved outcome for patients. So in the next couple minutes here, review the impact of data on quality improvement in the region, and then review some key data utilizations. And we'll talk quickly about accreditation, stroke distinction. We'll talk about the provincial annual stroke report. And then we'll really focus in on what we do as a region through our regional stroke monitoring and evaluation committee. So the process for quality improvement strategies regionally begins with an analysis of the current state. And this requires a fulsome data analysis. The majority of the work that we do is we start with an analysis of the data. The evaluation and then determine work plans to address where there may be a gap that we could improve upon. And then we utilize data to evaluate that quality improvement to ensure that the implementation of whatever work plan it may be has been successful and has had a positive impact on stroke care. So all quality improvement as a region really begins and ends with the need for accurate data. And this has a significant impact on stroke care within our region because, again, we look at this from an overall perspective, determining where there may be opportunities for improvement, and now analyze current state, looking at the data, implement work plans to address any opportunities for improvement, and then evaluate effectiveness through a data quality check moving forward as well. So data quality really is the sort of fundamental piece of where we drive our best practice implementation work plans. So in previous years, Hamilton Health Sciences underwent stroke distinction, and which is a form of accreditation which is very specific to stroke care. I'm incredibly happy to say that in May of 2025, multiple stroke sites within the Central South region will be undergoing stroke distinction, inclusive of the Regional Stroke Network. I want to stress how important that accurate data is to this process. And Rhonda can certainly jump in and add to this, but data is an essential part of the quality improvement that goes along with stroke distinction accreditation. So key metrics indicate improved and sustained performances, which leads to really better patient outcomes. Data is reviewed to help target areas where work plans and opportunities for improvement are needed in order to address Accreditation Canada standards. The data allows us to track our progress as we prepare for stroke distinction. Numerous indicators are required for stroke distinction from across the continuum of care, acute care, and rehabilitation. And even after we go through our accreditation process for stroke distinction, we're tasked with then reporting data to Accreditation Canada every 6 months. And so this is in an effort to ensure that we are maintaining our high quality of care and what we've achieved through the distinction process. And data is a key to the process of preparing for stroke distinction and then maintaining the standards of stroke distinction for all of our sites. So as you can see, the entire process of stroke distinction utilizes data from understanding our gaps, establishing work plans, demonstrating our achievements, and then maintaining accredited status. Excellent quality data is essential to this process and leads to better patient outcomes across our region. Accurately coded data is also essential in the production of our provincial stroke reports. Annually, Core Health Ontario releases a stroke report. The report pulls data from multiple sources to create a cross-continuum evaluation of the current performance. The report focuses on hyperacute, rehabilitation, and community aspects of care for persons with stroke in Ontario. It pulls data from a provincial perspective, a regional perspective, and even an organization by organization perspective. And this data is really crucial as it's a driver for change in stroke care across the province and across our region. We utilize this data for organizational priority setting meetings, and it's also utilized for our regional strategic planning. And finally, within the Central South region, we have a committee that specifically looks at stroke performance metrics on a quarterly basis. This committee is called our Regional Stroke Monitoring and Evaluation Committee. The committee looks at indicators across the continuum of care, inclusive of hyperacute care through to community stroke rehabilitation and even into long-term care admissions. This meeting is utilized to determine key successes regarding stroke performance in the region so that those centers can share their strategies for success, and hopefully those strategies can be taken up by other areas of the region. Just as well, opportunities for improvement are discussed, and looking at the data, we're able to determine opportunities to improve on those metrics. This is a table that is incredibly important within our region. It's essential to our development of quality improvement strategies to improve stroke care, as we are always trying to do across our region. I hope that the last few minutes has given a good overview of some of the work of the Central South Regional Stroke Network as we utilize data to form the foundation of our quality improvement initiatives and in the end, improve overall stroke care.